on his cliffhanger case.
Good afternoon, everyone. Thank you, Priya ma'am, Sang sir, and Rajesh sir for this opportunity. So I will be moving away from cataract surgery and going into refractive surgery a bit. This is my cliffhanger case. This case happened recently, and it actually was a cliffhanger where both the patient and I were stuck. So this is managing retained lenticules. So whenever we do a refractive procedure with lenticle extraction, there can be a condition where there can be an area which is left uncut, and in the pocket a part of the lenticule can be stuck. So removing that is not the easiest task. So if you see what is the etiology, when can we have such a remnant lenticule? The most common is having a black spot or a secretion of mebum on the cornea while the laser is firing. There can be a foreign body like an eyelash that comes between the cornea and the dock. Very thin lenticules can have breakups of the lenticules, and also for very difficult dissection or someone who is a trainee. So the prevention is, as soon as the lenticule is out, you should always inspect to see that the lenticule has come out wholly. And the major question is to treat or do not, whether that remnant lenticle should be removed or not removed. So dictum is, if it is causing a change in refraction, causing irregular astigmatism, it should be removed. So this is one case that was referred to us. This is the area of retained lenticle which you can see. Similarly, we see that steepening on the topography map, and also in the AIOC we can see a remnant lenticle. To remove this, Dr. Gidansha has prescribed a technique of injecting triamcinolone inside the pocket to delineate this lenticle and remove this. And also with the intraoperative AIOC and with the circle software, this can be removed. So this is my case. So this is a patient that we were operating on, was undergoing silk. If you can see, there is a small area which shows there is a small uncut area. Once you try and do a dissection in the anterior plane, the anterior plane comes out pretty easily. On the right, you can see the AIOC. In the AIOC, we can see we are in the anterior plane, and pretty easily the anterior lamina is dissected. Once that is done, then we try and go on to the posterior plane. So once we go into the posterior plane, we can see there is some area of difficulty in this area where there was a cold spot. We try using a duck-billed spatula to try and remove the lenticule, and we do a thorough dissection, and we are able to remove the lenticule. Once the lenticule is out, we inspect it, and you can see there is a small triangular pie-shaped area of lenticule which was left in situ. So we know that there is some part of the lenticule left inside, and luckily we have the intraoperative OCT, so we can see that there is the retained lenticule. Then again we spread it out, and this lenticule is discarded, and then we go again into the pocket. If you can see this cube of the anterior segment OCT, we are decreasing the size, that is the resolution is being increased. Once you decrease the cube, the resolution on the right increases, and we can see there is a small area of retained lenticule. This is what we are trying to remove. We are dissecting again and again and trying to remove that lenticule. If it stays in situ, it can cause irregular astigmatism. Again, this AIOC is showing us this area of irregularity where there is a stuck lenticule. We again try and remove these remnants, and we use a globe stabilizer to stabilize the globe, and use a forceps to remove as much as possible. And then we put a BCL, and we see the patient post-operatively. This is on day 1. You can see the patient has a small remnant lenticle fiber. The patient was 6-9 parts with the BCL on, and the AR shows a 1.5 cylinder. And then the patient is kept on steroids and thorough lubrication. And the patient at 1 week, if you can see, the patient is now plano. Patient was 6'6" without the BCL. There is a very small remnant lenticle in the pocket, but this is not causing any change in refraction or decrease in vision. So this is how we manage this case. Thank you.
Thank you, Dr. Ragav. And we keep facing such scenarios, particularly during our learning curve, or at times even if we have learned, if we become a bit casual, then these things can happen.
Yes, sir.
Any point you would like to add or conclude?
I think this is one thing which one has to, all the beginners should see that how to, separate and ultimately without breaking and leaving the small fragment.
Yes, sir.
You take the whole thing out, but ultimately it may take a little time, but it becomes fine because the whole system is such that nothing normally goes wrong unless you have created a lot of issues.
Yes, sir.
So in any case, you did it and controlled it well. So congratulations on that. And I think if there is no questions, we'll conclude the session here. And thank you very much.
Thank you, sir.